Welcome back to Dermcast.live. We are in the studios in Nashville, Smashville, Music City, Tennessee. And I am here today with Dr. Heather Goff, who's going to talk to us about cutaneous T-cell lymphoma. And hailing from Dallas, Texas, here's Dr. Heather Goff. How you doing, Dr. Goff?
Great. How are you doing today, Rob?
Good, good, good. Welcome to the Dermcast Live studios. And I can't wait to, this is a subject this is one that really worries me a little bit.
Okay.
So I have a lot of cool questions
Okay.
based on this and my own experiences.
Good.
And probably what I think people would want to know. So why don't you spin yourself a little bit? Tell us about yourself as a physician.
Okay, well, I have been in practice. I did my training at UT in San Antonio for both medical school and residency. Then I joined faculty at Northwestern in Chicago for a period of about 3 years. Then I did private practice for 4 years in a little town called Durango, Colorado. And then where I actually remained as an adjunct professor at Northwestern, and I did some adjunct teaching at the University of New Mexico. I've served on various committees with the American Academy of Dermatology. I've been involved with the development of their basic dermatology curriculum, which is free access online, and part of that working group. And I joined UT about 10 years ago, where I direct the Cutaneous T-Cell Lymphoma clinic and actually see B-cell lymphomas as well. I've been there for 10 years, and I direct the dermatology course at our medical school. So
awesome. Okay, so clearly you're a giant. We'll just say that. And in Dallas, Texas, currently. So
Yep.
Durango's not too far. I'm in Scottsdale,
Yeah.
Arizona.
Yep.
So it's not too far away. I know
Yeah.
some people from Durango. Okay.
Yep.
So we're gonna talk about cutaneous T-cell lymphoma. So
Yeah.
I'm gonna start this where most of us start
Yeah.
clinically.
Yeah.
Okay. Often, cutaneous T-cell lymphoma is something we stumble across. It's
Right.
not something that somebody comes in with that specific complaint.
Right.
Right. So, classic situation: a classic-looking eczema,
Yeah.
and that you see them for the first time. You biopsy, you're getting back spongiotic dermatitis.
Yeah.
So let's start with that.
Yeah.
Okay. I think that this is eczema.
Yeah.
I'm treating it. It starts to not go well.
Right.
Okay. And now you're starting to think, okay, maybe this isn't what I thought it was.
Right.
And with the presumption that this is maybe patch stage MF, where do I go from here? Like, what do I do to sort of sort this out?
Right. Well, what I would say in general first is that cutaneous lymphomas tend to have a preponderance in older individuals who may or may not, usually have not had a history of atopic dermatitis or eczema. And the lesions tend to be, in classic presentations, tend to be fixed lesions with relatively discrete edges on sun-protected sites. So if you see sort of like atrophic, wrinkly looking skin on sun-protected areas that may or may not be symptomatic on an older individual that are fixed and well demarcated, it probably isn't eczema, even if your biopsy comes back with spongiotic dermatitis, because atopic derm, as we all know, or nummular dermatitis. First of all, most of the nummular dermatitis I see is on the lower legs of older people, and it's usually excoriated and has a little bit of a irregular or ill-defined border, whereas mycosis fungoides usually has a relatively fixed and well-circumscribed border and hasn't been excoriated or manipulated quite as much, and so you're not seeing a lot of those secondary changes.
Great. So at this point, okay, you have a clinical suspicion
Yeah.
for MF, but nothing histo on
Yeah.
H&E, let's say.
Yeah.
What other diagnostics can I use?
So, I know I was taught that when you think it's mycosis fungoides, you should do a punch biopsy. But if you're looking at early stage disease and you're not looking at what you think is a tumor, or you don't think what you're looking at is a plaque, and you don't think there's a big dermal component, it's sort of like when you biopsy a nevus. If you think it's a really thick lesion, you may do a punch or you may do an excision, but if it's macular, you know that it's a dermal epidermal junction and it's a relatively shallow lesion. You can do a broad shave with margins. And the same is true, I think, in MF, that if it's a dermal epidermal junction inflammatory process with epidermotropism, if you're doing a little 4 millimeter punch, you may not have gotten the section that has those atypical lymphocytes that are invading the epidermis. And so a broader shave that's like, not necessarily even an aggressive scoop shave, but somewhat of a dermal shave where you're capturing all of the epidermis and some of the dermis in the biopsy, you're giving your pathologist more data because you're giving them a more breadth of the lesion. And so I tend to actually shave my cutaneous lymphoma, especially when in patch stage disease.
Great. So would you recommend doing multiple specimens?
Yes, and if they have multiple lesions or multiple sites of involvement, then you can take biopsies from not just one but 2 sites. And if the patient's you try to find a lesion that hasn't been being treated. Sometimes if they've been using a steroid or they've been using a retinoid or any other topical, that can obscure some of the epidermal findings, particularly the use of steroids across the surface of the skin can inhibit the epidermotropism that you might see. So if they've been recently treating with a topical steroid, you may be obliterating some of the histologic findings. So ideally, that's going to be an untreated lesion.
Got it. So, and do you tend to gravitate to the lesions that, for instance, might be in the typical areas? For instance, you mentioned sun protected.
Yeah.
That's where you're taking your biopsies.
Yeah.
Okay.
Just like anything, you are kind of trying to biopsy what you think is the most representative of the eruption that you're seeing.
Okay.
Yeah.
Got it. So, okay, so let's advance the situation now.
Yeah.
We have this dermatosis spongiotic, not responding to therapy.
Yeah.
So you already have that initial biopsy. When do you want to biopsy again for more answers, or do you start turning towards therapeutics? Where are we now?
So I think that, one of the things that my residency program director used to say that I still really believe strongly is that if you're doing the right thing for what you think is the right diagnosis and the patient isn't getting better, the problem probably isn't your treatment, it's your diagnosis. And so it's always important to be able to question ourselves. I constantly, question myself and question, okay, am I doing the right thing here? Am I barking up the wrong tree? Am I landing in the right diagnostic category? It's important to forgive ourselves as clinicians with this disease state because it's extremely difficult to diagnose both clinically and histologically. It's one of the great mimickers. One of the jokes in our dermatology grand rounds when the residents are being questioned as to what they think the differential might be is that, if no one has said syphilis, no one said mycosis fungoides, no one said drug eruption, and no one said sarcoid, that you can say any of those because they are great mimickers of all dermatologic conditions. And so mycosis fungoides is known to be a great mimicker of almost any other dermatosis. And if you look at the average number of biopsies that any individual who has the diagnosis, it can take a period of 6 or more years with 6 or more biopsies over that time period to establish the diagnosis. So rare is the patient that gets the single biopsy for the recently arisen eruption that then all of a sudden was sort of discovered to be mycosis fungoides. So I think it's okay, to have given a steroid and then be like, okay, it's not getting better. Maybe do I have the right diagnosis? I've been calling this eczema, but this patient isn't improving. Let me repeat a biopsy. Oh my goodness, it's cutaneous lymphoma. I think that's still okay. The whole idea in medicine is that you don't want to do any harm, and I don't think a lot of those patients in early stage disease have received any harm. Okay,
so again, you're in the situation, they're not getting better, and then MF enters your differential. You mentioned sort of, epidermal, sort of obliteration from, let's say, corticosteroid use.
Yeah.
Are you waiting to do a biopsy so there's some epidermal recovery? Or,
you can have them take a steroid holiday for a period of 2 or more weeks to see if you can kind of reestablish what's going on there. But ideally, the patient's there, it's hard to get people to come back to clinic. Coming to clinic is an inconvenient process. So I just try to find a lesion that hasn't been being treated and just biopsy that for convenience sake. But if there is no site that's been untreated, then a drug holiday is reasonable.
Okay. So you can still get, you mentioned 6 years, 6 biopsies,
Yeah.
you know, for average numbers before
Yeah.
diagnosis. So, okay, now you're still in no man's land, right?
Yeah.
So let's say you even do a second biopsy, spongiotic dermatitis, it's still ambiguous.
Yeah.
Your suspicions are still high clinically. When are you comfortable actually initiating treatments? Because some of them are not necessarily the easiest things to
Yeah.
do. So where do you start implementing
So
therapy?
what I always am thinking about is I'm always thinking about what I want to do to help the patient. So I want to help the patient. I want the rash to get better, whatever the eruption is. But I also want to do no harm. So I always feel like, well, if I'm thinking somewhere in the back of my head that this could be mycosis fungoides and it's somewhere in my differential, and I'm looking at them and I'm like, clinically I'm suspicious, I just don't have that histology to help me clinch the diagnosis, then I'm sort of thinking, well, whatever I choose, I want to choose something that if they have mycosis fungoides, and I'm calling it eczema for ease of documentation, let's say, or just because I don't want to label them with a malignancy without a clear-cut diagnosis of that, then I want to pick a therapeutic option that's going to not harm them if they have a cutaneous lymphoma. So that's where I think phototherapy, narrowband UVB, is one of my favorite treatments because it works for psoriasis, it works for atopic dermatitis, and it works for mycosis fungoides. And so it's a great go-to regardless of what diagnostic category you think you might be in. And then secondly, topical retinoids are generally very effective. And like tazarotene, for instance, is FDA approved in the use of psoriasis. So it's on label for that diagnosis. And there are other retinoids like bexarotene that are FDA approved for the treatment of mycosis fungoides. But tazarotene has also been studied by Madeline Duvik years ago in the treatment of mycosis fungoides and was found to be effective as well. So it can be used off-label in the treatment of MF and combined with phototherapy. So sometimes I'll have a patient start something like a topical retinoid and phototherapy and sort of see where we get. If they're more psoriasiform and less eczematous. If it's eczematous, then maybe a little steroid and phototherapy.
Okay. So narrowband UVB, I love using this for many reasons,
Yeah.
but I'm lucky, you know, to have access to it. It's
Yep.
difficult sometimes. Are you into home UVB?
I do.
Something?
So I believe that narrowband is one of the best overall first line treatments when you suspect MF and you're uncertain of the differential. Particularly, it helps control itch and it helps control the inflammation. And a lot of data suggests that it can put patients into remission in early stage disease, that when they have plaque or patch stage disease, I should say. We not infrequently will write home phototherapy units. There's a little bit of sort of duking it out with insurance companies to get those covered. One generally has to show that UV light of some sort has been effective. So for those patients that live 2 or 3 hours away from an in-office phototherapy unit, we may even do something like, first we document that to the insurance company, but we'll comment on things like areas that are photo exposed are clear or in remission, and areas that are involved are the more photo protected areas. And so even being able to show that even natural UV exposure seems to be disease modifying can be sufficient to get a home phototherapy unit covered for those who live far away from an in-office unit.
Okay, great. So in our scenario now, we're still ambiguous. We don't have H&E, or we don't have histology to back up our diagnosis. We're
Yeah.
running on clinical suspicion at this point.
Mm-hmm.
You're using pretty safe treatments so that you know if it's an actual spongiotic eczema,
Yeah.
that you're not going to cause any harm.
Right.
Okay, so you've got light, maybe topicals
Yeah.
that are not going to cause any risk. When are you going to biopsy again, if at all?
I would say that if so they're on their phototherapy, they're on whatever topicals you put them on. If the patient continues to do worse and their rash does not improve, whatever their eruption is, continues to not improve and continues to get worse, then of course I'm going to repeat a biopsy. But if it clears and everything's going well, no harm, no foul, you've made the patient better. And I don't really worry about repeat biopsying because you're not necessarily going to see much on histology.
Okay.
Yeah.
And so let's take best case scenario. They're getting better.
Yep.
So if there's recurrence, where are you starting with that? What do you do when you start to see recurrence?
Yeah, so then we may, at that point, let's say it was clear and now there's some relapse of whatever the original dermatosis was, we may repeat their biopsy unless there was something that sort of caused, like let's say they were clear on phototherapy and now they've stopped their phototherapy and it's been, 3, 6, 12 months since they've done their last phototherapy and all of a sudden whatever the eruption was is back again. If you don't have a clear-cut diagnosis, it's not wrong to repeat a biopsy, but if you also know they cleared previously with phototherapy, they're probably going to clear again, and many times we'll just say, we know this worked for you before, let's go ahead and use it again.
Okay, and so let me flip this a little bit.
Yep.
So UVB, it's great because we know we can treat, like let's say a classic eczema,
Yep.
It'll work
Yep.
for narrowband UVB as well as for MF.
Yep.
So is there a situation where you might think, I'm not getting this better now, let's say with light, we're struggling here.
Yeah.
And you're still struggling with, okay, atopic derm, MF. When are you okay trying something systemically for atopic dermatitis if you're still in no man's land with the diagnosis?
Yeah, that's a great question. I think that in those patients, probably most people are never going to start a systemic for like 1, 2, 3, 4% body surface area. You're looking at someone who's got 30, 40, 50% body surface involvement and they're very pruritic. There's an eruption on a large part of their body. Those are patients where I really do want to know what it is that's going on, because those are the patients where you're starting to look at doing systemic treatments like a JAK inhibitor or like a dupilumab or a other biologic, TNF alpha inhibitor, an IL-23 inhibitor, whatever. You're not sure if it's psoriasis, if it's atopic derm, if it's mycosis fungoides. So in those patients, I'm taking usually 2, 3 biopsies from various parts of their eruption. I'm asking my dermatopathologist to do all of the appropriate staining, a CD4, a CD8, a CD7 for evaluating and for mycosis fungoides, and then also potentially doing even things like a flow cytometry, a CBC, an LDH, et cetera, to try and determine what the nature of their eruption is. And then, in general with those patients, I'm still starting with phototherapy. I'm sometimes starting with a low dose oral acitretin, like 25 milligrams 2 or 3 times a week to kind of potentiate the phototherapy. And then if they're not improving, the biopsies may help is it more psoriasiform looking? Is it more spongiotic looking? And so in those patients, and then what other symptoms do they have? Do they have itch? Then I'm trying to control their itch with some other medications. And then I think that it's really kind of a no harm, no foul if you're like, this is really looking psoriasiform under the microscope, and I find no findings of, there is no clone in the skin. There is no, discordance, like an epidermal dermal discordance of the CD4 and CD8 cells, that there's, the ratios aren't abnormal. The 4-to-8 ratio isn't abnormal. There's not a loss of CD7. So there's not any of these other markers that would sort of like tip you towards like, is this more like MF looking? And you're looking more psoriasiform or you're looking more spongiotic, then I think there's nothing wrong with employment of a biologic, because that also can sort of be your, that can be a diagnostic tool, right? Mm-hmm. If you're like, okay, you all of a sudden, I put you on dupilumab and now you're totally clear,
right. The answer
then you kind of have an answer, right?
Right.
Generally, if it's mycosis fungoides or Sézary syndrome, they're not going to respond very well to dupilumab. Or an IL-17 inhibitor or an IL-23
Okay.
inhibitor. They may temporarily seem better, but then they continue to do worse and they continue to have an eruption. And that's when you have to sort of still go back and sort of scratch your head and go, okay, like what's going on here?
Okay.
And then also still forgive yourself. You know, you had the psoriasiform eruption on histology, you started the biologic, you know, and we go, okay, wait, they're not getting better. Repeating a biopsy is, I think, really important at that point.
Okay, so
Yeah.
basically I'm hearing, you know, if you get to that point where you might have to go back to systemic disease because now the atopic derm is still in the mix,
Yeah.
let's say, that you really want to know. And I think it's, you know, the medicines you mentioned, you know, IL inhibition, TNF
Yeah.
alpha inhibition, I mean, some of them are problematic in terms of being lymphoproliferative,
Correct.
potentially.
Yep.
But so let me ask you this, as sort of a sidebar question, IL-13, do you have a level of comfort in doing that in this situation? You know, as far as I understand IL-13, because the clinical situations can come up, right? Is
Yeah.
it MF? Is it atopic derm?
Yeah.
You want to use IL-13 inhibition.
Yeah.
As far as I understand it,
Yeah.
there is low or believed to be low risk for something lymphoproliferative risks with IL-13.
Yeah.
How do you feel about that?
So the answer is, you know, there was recently an article on dupilumab sort of like flaring or unmasking undiagnosed Sézary syndrome or unmasking undiagnosed mycosis fungoides. And I mean, maybe it's an unmasking, or maybe it's someone who looked spongiotic on the biopsy and the doctor was doing all the right and appropriate things and the patient's not getting better. They put them on dupilumab, and then lo and behold, their atopic derm isn't improving, and then you biopsy and you go, oh, okay, now I see that they do have mycosis fungoides or they do have Sézary syndrome. It's not, I don't think that the dupilumab is necessarily provoking that or causing it, so I don't think it's really lymphoproliferative. Maybe what it's doing is just sort of telling you this patient's not really responding to that therapy, and maybe it's calming down enough of the inflammation that you can all of a sudden sort of see the malignant cells because you're calming some of that background inflammation. Right. But I don't necessarily think it's provoking it in any sense, but it may be making it evident.
Okay.
Yeah.
So let's move on to you know, the other aspects of management.
Yeah.
When do you refer to an oncologist?
Generally when they're going to be receiving systemic chemotherapy. So this is generally going to be a patient. My treatment algorithm in dermatology, I go as far as managing their interferon alpha shots and oral targretin pills. And so I'm pretty comfortable with the management of those medications. I'm not suggesting that everybody should be comfortable with managing those medications. I think everybody has different levels of comfort. But I go as far as managing oral targretin and interferon. I know other dermatologists who manage histone deacetylase inhibitors like romidepsin. But I typically, mostly institutionally, those are written by oncologists and administered in the cancer center. And so I have a close relationship with a few oncologists that see almost exclusively my cutaneous lymphoma patients that require systemic therapy. We're in a large metropolitan area with a big referral base. And so we have enough patients that I have sort of a dedicated oncologist that's sort of what they do. But I think it would be important for physician assistants or dermatologists in communities to have an oncologist with whom they have a close relationship, that knowing that we probably know sometimes a little bit more about this disease state than our oncology colleagues because it's such a niche, and we end up seeing more of it because the initial manifestation is a lot of times in the skin, so they come through by way of derm. And so it's important for us to know what sort of the systemic treatment algorithm is as well. We typically start with a histone deacetylase inhibitor like romidepsin. But mogamulizumab is also a chemotherapeutic agent that's utilized. And then we have sort of rescue chemo that we use as well. So
Okay.
yeah.
So then in terms of long-term management, let's sort of stick with our scenario. Let's say you've gotten them stable with light and you're feeling pretty good about chemo-controlled. Long-term management then beyond this for chronicity and so forth, is there any benefit to them seeing an oncologist for any kind of evaluation? Or are you just doing age-appropriate, checks with the PCP, and then you're seeing them for their skin exams?
Yeah, age-appropriate screening, but if they have widespread plaques, like plaques greater than 10%, or tumors at any stage, or any patient that develops B symptoms or has anything that you think is a kind of more stable over time enlarged lymph node, so any kind of lymphadenopathy that's not transient from an infection, let's say, those patients I think deserve full body imaging like CT, chest, abdomen, pelvis, or a PET CT of their whole body, depending on what their insurance will cover, to assess for lymph node enlargement. The cutoff for lymphadenopathy in cutaneous lymphomas is 1.5 centimeters, so you're looking for nodes that are sort of larger than that to see if they need to be biopsied.
Okay.
So.
And in terms of recurrence then?
Yeah.
So talk to me again, and again, that's a broad topic across many kinds of T-cell lymphomas, but again, let's look at, like classic patch stage MF.
Yeah.
What is recurrence like once you treat them? Let's say you get them better. What is recurrence like over time?
So this is a great question. This is kind of, I probably think about this a little bit differently than maybe not my colleagues in cutaneous lymphoma, but I think differently than what you might read in a textbook. And that's that I think that just like, ductal breast cancer, now we used to just say it was all breast cancer, and now there's like HER positive and HER negative and triple negative and estrogen positive, progesterone positive, estrogen positive but not estrogen, estrogen receptor blocker, responder, et cetera. Like we are differentiating all these different kinds of breast cancer. I think that the clinical manifestations of mycosis fungoides are similar, and the staging is always based on that it's cutaneous, that it's a CD4 positive malignancy of the skin, T-cell malignancy of the skin. And it's all sort of in this mycosis fungoides staging algorithm. But my belief is that, there's not just like we know in psoriasis and eczema, there's not just one T-cell type in your skin. And so when you have the malignant degeneration of a CD4 positive T-cell in your skin, my belief is that the trajectory of the disease is set almost somewhat, it's based on temporality, like how long that malignant cell has to mutate and acquire new mutations. So duration of disease is important, but also what the phenotypic behavior is of that malignantly degenerating T cell from the outset of the disease. So if you look at the CD4 positive T cell compartment of the skin, there's variability in those CD4 cells to egress the skin. In other words, some CD4 positive T cells are much more epidermally bound than other CD4 positive T cells that may retain some of the surface markers that allow them to enter lymphatics or the bloodstream. Whereas others lose those markers completely once they enter the skin, and they become highly epidermally restricted and bound to the epidermis. So my personal belief is that patch stage disease is a disease, and also hypopigmented MF, which tends to be CD8 positive. If you look at CD8 positive T cells, they're extremely, when they're resident memory T cells, they're CD8 positive resident memory T cells, they're highly epidermally restricted, and they lose almost all of their capacity to exit the skin. And so once they're there, they're sort of stuck there. Versus CD4 cells and their varying capacities, some are really stuck there, and others have greater ability to migrate and live in different parts or different compartments of the dermis. And so my personal belief is that some patients start off with really thick plaques, and those are ones that may evolve to tumors, Or some patients start off just with de novo tumors, and they're really different. Their biology over time is extremely different than a patient who has just these sort of indolent patches that are just hanging out and hanging out and hanging out and not doing much. So the way I'm going to manage and worry about those patients is extremely different. When I worry is when a patient's got plaques that are thick, that are becoming broken down and compromised and infected. Because when patients die of cutaneous lymphoma, they tend to not die of their cutaneous lymphoma, most of them. They tend to die of sepsis and infections introduced through the skin, just like patients used to die of pemphigus years ago before we had drugs like rituximab to control the disease. They, essentially died because your skin barrier is so compromised that essentially you get an infection in your bloodstream. And because patients with lymphomas are already a little bit immunocompromised, they just can't clear that infection and they die of sepsis. And so I don't know if that really answers your question. I kind of like went off on a tangent there.
No, that's okay. Let me just ask this, and you can say, I'll ask then in terms of management, are you comfortable seeing them then how many times a year? I'll just ask that. Okay.
I think it depends on, it's how much I'm.
You know what, let's create a pause and then I'll ask.
Yeah.
Okay. So it sounds like, genetics, clonality, these things don't change, and then the ability of cells to migrate or not can be affect the severity of the disease can affect what recurrence might be like.
Yeah.
So I think in sum, are you okay seeing how comfortable are you? How many times a year would you want to see someone and be comfortable in terms of monitoring them appropriately?
I think that it's just going to be, with MF, it's a lot like you would with your atopic dermatitis patient. So they're not all the same. It's how bad does the patient look? Do they look infected? Does their skin look broken down? Do they have tumors? Are they ulcerated? Those are patients that I'm going to see back with much more frequency and regularity than a patient who had one little patch that went away with phototherapy that's completely clear. Those patients I may see once a year or even once every 2 years if they're completely clear and on home phototherapy or maybe clear off of phototherapy.
Okay, great. So let's turn to one last situation here because this is important, I think, for all clinicians. This is one of the things we worry about is erythrodermic disease.
Yeah.
Because this can turn into pretty bad situations.
Yeah.
So how do you approach a truly erythrodermic MF?
Yeah.
What is your approach?
Yeah. Well, first, I think any new onset erythroderma has to have a flow cytometry to look for phenotypically abnormal T cells. You have to know it's a lab test that's drawn. It's a blood test. It's read by a pathologist. They have to have a CD4, a CD7, and a CD26 that's in the panel because the phenotype of a Sézary cell is CD4 negative, CD4 positive, CD7 negative, CD26 negative, or a CD4 to CD8 ratio of greater than 10:1. So they have to have the right markers for the right CD markers in the panel that's being ordered. One also has to have a rearrangement or looking for clonality, so identical T cells in that blood sample. So those have to be done, I think, on every erythrodermic patient. If they don't have some clear-cut, long-standing history since childhood of psoriasis that's known to respond to anti-psoriatic therapies in the past. So if I see a patient that's older, de novo erythroderma, flow cytometry is an automatic part of the workup because the home of the Sézary cell is a central memory T cell that resides in the bloodstream that only temporarily sort of traverses into the epidermis and then re-enters the bloodstream. And so if you do a biopsy, 30% of skin biopsies in erythroderma are nonspecific. And so you can't say that you've safely ruled out Sézary through a biopsy of the skin.
Okay, so let's say in a situation where through diagnostics you're confident this is CTCL. Well, let's say it's anything T-cell lymphoproliferative, okay?
Yeah.
And your erythroderma, you know it's what it is.
Yeah.
What is your therapeutic approach?
So first line, typically, if they have blood involvement and we know it's Sézary, or they have, let's say, a high proportion of malignant cells in their bloodstream, we may, but not yet enough for Sézary, so they're not greater than 30%. Let's say they're like, 15, 20% or something, and they're erythrodermic, and so we know they have MF. We may use extracorporeal photopheresis. We typically still will use phototherapy. We will use low-dose oral acitretin, which is part of NCCN guidelines, but is considered off-label in the use of mycosis fungoides. Or we use oral targretin pills in those patients, and plus or minus interferon alpha injections. I typically combine interferon alpha injections with acitretin, but when I've combined it with targretin or bexarotene, it typically causes neutropenia. I'm probably getting too nuanced here, but so I don't combine bexarotene and interferon as frequently. Sorry, I'm not trying to get down a rabbit hole, but and then we are usually collaborating with oncology and starting a histone deacetylase inhibitor, or starting them on mogamulizumab, so some other systemic chemotherapeutic agent.
Okay, excellent. So, well, I mean, a lot of this is very clearly the disease. It can be confusing, obviously, and many of us just get stuck. As I said, we get stuck before we start, because of the ambiguity in diagnosis, and it's such a broad-reaching disease in terms of presentation and progression. That a lot of this is the practicality of sort of working it up is always useful information. Well, thank you so much.
Thanks so much.
For taking
it's really fun
to take a minute to talk to us here, and we got to have you back to talk about some other things.
Okay, cool. I mean, cosmetics are fun too. I mean, I do all the resident teaching in cosmetic derm at UT, but it's that I think. I mean, the most exciting thing there, I think, is just going to be the. I'm excited about, we don't do autologous fat. I think it's mostly our plastic surgery colleagues, but I'm excited about early reports about autologous fat use in for hands and fingers in scleroderma patients, improving their digital ulcers. So
that's great.
I think that's going to be kind of the wave of the future in the management of scleroderma.
Well, that sounds like a great topic for another interview, but thank you so much for stopping by with Dermcast.live, spending some time with us on this difficult topic. And is there any way people can get a hold of you? Do you have?
They can always email me. My email is heather.goff, Goff, at utsouthwestern.edu. So I'm always happy to get people's emails, and we often work patients in, and I'm also comfortable, just chatting with someone on the phone if they have just some basic clinical questions. So,
awesome. And do you have an Instagram account for your cosmetic stuff?
I do not have an Instagram account for my cosmetic stuff. I have an Instagram account that's personal for like some of the artwork that I do on the side as a hobby. And it's actually named after, it's Les Moulages, LESMOULAGES. That's my Instagram handle. And it has to do with, in early dermatology, they use these wax models for diagnosis. Anyway, it's a reference to how art was used to teach early dermatologists in their careers.
That's great. That's fascinating. Anyway, okay, well, we'll put that up so people can find it.
Good. Okay.
All right, awesome. Thanks again for coming by, and it's great to have you.
Yeah, thank you.
Thank you.
All right.
Once again, thanks for stopping by Dermcast Live. Rob Casquejo in Nashville, Tennessee.